Assalamu alaikum. Hello everyone. I'm Hoor Ameen, a fourth year medical student. In this video, I'm going to explain section 9 of the central nervous system chapter, which is about brain injuries. So let's start. We will start with traumatic brain injuries. Now, brain damage is caused not only by localized injury at the site of the blow, but also by ricocheting brain hitting the opposite end of the skull. What does that mean? Let me show you this picture. So as you can see here, this is the primary impact of the trauma. So the brain strikes the skull on the side of the impact, anteriorly. But then what happens when the brain bounces off the primary surface, it impacts against the opposite side of the skull. So the brain here will rub against the inner ridges of the skull, leading to an injury to the opposite side of the impact. So this is what is called a concussion. Concussion اللي هي بالعربي الارتجاج الدماغ. So this concussion is let's say a temporary condition. It has temporary signs and symptoms. It leads to alteration in brain function, which is usually temporary, following a blow to the head. So what might happen? The patient might have dizziness, loss of consciousness, but if this concussion happens repeatedly, this will accumulate the damage, which will lead to a persistent or a permanent neurological damage. So permanent neurological damage happens only after repetitive concussions, leading to a condition called contusion. Contusion اللي هي كدمة. إذن it starts with a concussion, مجرد ارتجاج, which is temporary, and then if it happens repetitively, it will lead to contusion, which is a permanent damage, كدمة. Following a head injury, death may result from subdural or subarachnoid hemorrhage, which is bleeding from ruptured vessels into those spaces. We discussed those spaces in the previous video, so make sure to see them. I will show you here what do they mean. So remember, we had three meninges, the dura mater, the arachnoid mater, and the pia mater, and we discussed two important spaces within these meninges, which is the subdural space just below the subdura and the subarachnoid space, this one in green, the green zone. So sometimes, because these spaces have blood vessels, they are liable to injury. So if injury happens, it leads to hemorrhage within these spaces, leading to subdural hematoma or subarachnoid hematoma as seen here, and these are fatal conditions that may lead to death. Now, blood accumulating in the skull increases intracranial pressure and compresses brain tissue. That's why it's fatal. If the pressure forces the brainstem inferiorly through the foramen magnum, control of blood pressure, heart rate, and respiration is lost. This is very important. An injury to the brainstem is much dangerous than an injury to the brain, because the brainstem has the centers of breathing, blood pressure regulation, the body temperature, the heart rate, and so on. So if an injury happens leading to a downward force of the brainstem towards the foramen magnum or below the foramen magnum, these vital regulations or vital processes of our body will be lost. Another consequence of traumatic head injury is cerebral edema and swelling of the brain. Okay, now moving to cerebrovascular accidents, which are also called strokes. Stroke اللي هي السكتة الدماغية. سكتة يعني أكو شيء توقف، في شيء توقف, which is the blood supply. So, a stroke occurs when blood circulation to a brain area is blocked and brain tissue dies of ischemia. So ischemia is a condition in which there is no blood supply to an organ, so it's deprived of blood. This will lead to death, of course. Now, what might cause this ischemia? What hinders the blood supply? The most common cause of strokes is a blood clot that blocks the cerebral artery. We know that the brain is supplied by the cerebral arteries. So if there is any block within the cerebral artery, it will be ischemic. Also, another cause might be atherosclerosis within the artery, leading to narrowing of the artery. Now, those who survive a cerebrovascular accident or a stroke are paralyzed on one side of the body. This is called hemiplegia, الشلل النصفي. Look at this image. If there is a stroke on the right side of the brain, this will lead to hemiplegia or paralysis of the left side of the body, and vice versa. If it was on the left side, it will lead to hemiplegia on the right side of the body. This will also may happen or cause sensory deficits. So the patient will have difficulty understanding or vocalizing speech, because in the brain we have certain areas for speech vocalization, for understanding. So these areas, if they were ischemic due to a stroke, a clot within the arteries that supply them, this will lead to impairment in these functions. Also, not the sensory function, but the motor function will be impaired. So, starting physical therapy as soon as possible is very important in such conditions, because we want to prevent a condition called muscle contracture. Muscle contracture is a permanent shortening of the muscles. يعني they become tightened. حيصير في عندنا تقلص بالعضلات. What's the cause? It's because of the immobilization. When you immobilize, if the patient is immobilized for a long period of time, the muscles will start shortening and tightening, leading to contractures. So we want to prevent this by early physical therapy. Now, sometimes we have temporary episodes of cerebral ischemia. These are reversible episodes. These are called transient ischemic attacks. Yani it's not a stroke, but we can call it a mini stroke. So what's the difference? Look here. This is the stroke that we were discussing. This is the cerebral artery, and it is blocked by a clot here, preventing blood from reaching the brain area. This leads to the permanent damage. However, sometimes we have small clots that hinder the blood supply, but doesn't block the blood supply totally. So we have just small amounts of blood flowing within the arteries. This will cause the transient ischemic attack. So that's why we call it a mini stroke. So it will be reversible. In these episodes, there will be temporary numbness, paralysis, or impaired speech. So it always, when we have strokes, we will impair the sensory and the motor functions. So sensory function, it may lead to numbness. Motor function may lead to paralysis, and also the speech. Now, one thing that happens in strokes is that the neurons will die because the brain area is dead, right? So when the neurons within these areas start to die, they start disintegrating, and they flush out all what they have of neurotransmitters and so on. So one of the important neurotransmitters released when the neurons die is glutamate. Glutamate is an important neurotransmitter that plays a key role in learning and memory and other critical brain functions. Now, when the neurons start to unleash the cellular equivalents and increase the glutamate within the extracellular compartment, this glutamate flushing will lead to abnormal excitation of the surrounding cells, because glutamate acts as an excitotoxin. Yani it's a substance that causes excitation. So when the neurons die and start releasing glutamate uncontrollably, this will lead to uncontrollable excitation of the surrounding cells, which might lead to death. Now, at present, the most successful treatment for stroke is tissue plasminogen activator. This is a drug that we give to patients with stroke to dissolve the blood clot in the brain. So by giving this drug, this will be dissolved and the brain will resume its blood supply. Alright, so that was for the strokes. Now moving to the degenerative brain disorders. We have two degenerative brain disorders that we will be discussing: Alzheimer's disease and three, and Huntington's. Okay, we will start with Alzheimer's disease. Alzheimer's is a progressive degenerative disease of the brain ultimately resulting in dementia, which is mental deterioration. Now, how does it start? Patients with Alzheimer's disease usually start with memory loss, particularly for recent events. They also have shortened attention span, disorientation, and eventual language loss. So it happens in steps. It starts with memory loss, then it leads to shortened attention, then disorientation, then impaired language, and so on. Over a period of several years, formerly good-natured people may become irritable, moody, and confused. طيب. So these are the clinical features of Alzheimer's disease. Now, what's the hallmark of Alzheimer's disease? What happens in the brain? What's the pathophysiology? I want you to remember two important hallmarks. These are keywords in Alzheimer's disease. We have senile plaques. So we have senile plaques and neurofibrillary tangles. I will start with this image before. So see here, this is the normal brain tissue. We have the neurons and the extracellular matrix. They are clean and good. In Alzheimer's disease, we have intracellular and extracellular, let's say, hallmarks. Okay? The intracellular hallmark is the neurofibrillary tangles, and the extracellular hallmark is the amyloid plaques. What's happening? I'll tell you. In patients with Alzheimer's disease, usually they have a gene defect. Those who have APP gene, which is the amyloid precursor protein. What happens is that normally this protein is found within our cells, okay? And this protein should be cut usually at specific points. We dispose of this and this, and we keep this protein within the cells, and everything will be fine. But those with Alzheimer's disease have a different story. The cutting of the APP protein, the amyloid precursor protein, is somehow not optimal. What happens? It will be cut in a way that is not healthy, leading to a disposal of all this components of the protein. So the whole component here will be disposed. Now this component will get out of the cells, and it is insoluble. So that's why it will form aggregates, because it's insoluble. It forms aggregates, and it starts accumulating within the extracellular matrix, leading to the formation of these amyloid plaques. So again, these amyloid plaques are also called senile plaques or beta amyloid plaques. So let's read. Examination of brain tissue reveals senile plaques littering the brain like shrapnel between the neurons. So it's extracellular. The plaques consist of extracellular aggregation of beta amyloid peptide, which is cut from a normal membrane precursor protein, which is the APP, amyloid precursor protein, by enzymes. So this is the APP, and it's cut in a way that leads to aggregation of insoluble proteins. One form of Alzheimer's disease is caused by an inherited mutation in the gene for PPP, which suggests that too much beta amyloid may be toxic. Current clinical trials focus on using the immune system to clear away beta amyloid peptide. Alright, now another hallmark of the Alzheimer's disease is the presence of neurofibrillary tangles. These are inside the neurons, as you can see here. They are inside. Now inside the neurons we have a protein called tau protein. Here we have tau protein. These tau proteins have some functions within the cells. But what happens in Alzheimer's disease, these tau proteins start bridging with each other. They start accumulating for some reason. Okay? So as they accumulate and as they grab one another, they form these tangles within the cells. And as the number of these tangles increase, the cognitive impairment will be higher. Okay, so the number of tangles within the cell is a sign of the cognitive impairment in those patients. So clinic here, Alzheimer's disease is the presence of neurofibrillary tangles inside neurons. These tangles involve a protein called tau, which functions like railroad tie to bind microtubules or track together. In the brains of 80 patients, tau abandons its microtubule stabilizing role and grabs onto other tau molecules, leading to formation of this spaghetti-like neurofibrillary tangles, which kill the neurons and disrupt their transport mechanism. So we have both neurofibrillary tangles and senile plaques. These are the important hallmarks. Now this happens due to misfolding of the proteins that clump together and also catalyze the misfolding of normally folded copies of the same proteins. So this misfolding spreads in a predictable way from one region of the brain to another. So it starts in one region and it spreads to other regions. What are the regions that are usually affected in Alzheimer's disease? We have the hippocampus, the basal forebrain, and the association areas of the cortex, and these areas are especially important for thinking and memory. That's why Alzheimer's disease usually starts with a memory loss, cognitive impairment, and then it deteriorates to dementia. Now, neurons that use also the neurotransmitter acetylcholine are particularly vulnerable during this Alzheimer's disease. So that's why we use acetylcholine inhibitors, acetylcholinesterase inhibitors, or a drug that inhibits the breakdown of acetylcholine in order to increase acetylcholine within the brain and enhance the cognitive function in Alzheimer's disease patients. You can see here, this is the healthy brain, and this is a brain of severe Alzheimer's disease because the brain tissue is dead, the brain starts shrinking. Now moving to Parkinson's disease. Parkinson's disease is also a degenerative disease, but the problem here is that we have degeneration of the dopamine releasing neurons of the substantia nigra. Substantia nigra is a basal nucleus within the brain. Just remember its name for now. This releases dopamine, which is important for many functions within the brain. So there will be a deficiency of dopamine within the cells, leading to impairment in the function of the basal nuclei. Basal nuclei usually regulate the motor functions of our body. So if there is no dopamine, the motor functions of our body will be disrupted. So what will happen? Parkinson's disease patients will present with persistent tremor at rest. This is important. Usually their tremors are increased at rest, and when they do movements, the tremor decreases. Also, they have a forward bent walking posture and shuffling gait and a stiff facial expression. And they also are slow initiating and executing movements. So usually they'll tell you, when I wake up in the morning, I have difficulty getting up from the bed, I have difficulty getting up from the chair, doing movements or starting a job. So you can see here, they have this masked face, no expressions, they have this stooped posture, they have this hand tremors, the shuffling short stepped gait, also their flexed hips and knees. So this is the typical presentation of Parkinson's disease. Now, this disease, of course, becomes more common with age. We said it's degenerative, so it increases with age. It's the cause of this Parkinson's disease is still unknown. However, we have some multiple factors that we interact to destroy the dopamine-releasing neurons. Recent evidence points to abnormalities in certain mitochondrial proteins and protein degeneration pathways, just to memorize this. Now, what do we use in this Parkinson's disease? Because we have deficiency of dopamine, so we will supply them with dopamine. We'll give them L-Dopa. This is a drug that resembles dopamine, and it helps to alleviate their symptoms. But the problem is that this drug is only good at the early stages of this disease. because we still have the neurons to supply them with dopamine. However, in an advanced stage, the neurons will die. So even if you supply the neurons with dopamine, there are no neurons. So dopamine has nothing to do. So it's only important in earlier conditions. So it passes through the blood-brain barrier, this L-DOPA, because it's lipid soluble, and then it's converted into dopamine. However, as more and more neurons die off, L-DOPA becomes ineffective. Now, usually when we give drugs, we try to give a combination of drugs because this will allow us to use low doses and will give us good effects. So we mix L-DOPA with drugs that inhibit the breakdown of dopamine. Remember, we have a deficiency of dopamine due to degeneration of the neurons that release dopamine. So we can give the L-DOPA and we can give a drug that inhibits the breakdown of dopamine. Now, as we said, this is early in the disease, so it can slow the neurological deterioration. However, later on, we will need further management. So after L-DOPA, we can do deep brain stimulation. So L-DOPA is first. Then we have deep brain stimulation. This is late in the disease. This is due to via implanted electrodes that shut down the abnormal brain activity and can alleviate tremors. Remember that this is for patients who are no longer responding to drug therapy, and it's risky. Another possible future treatment is to use gene therapy to insert into adult brain cells the genes that could cause them to secrete the GABA, which is an inhibitory neurotransmitter. It inhibits the abnormal brain activities. Yani hopefully we can use this in the future. Also, we want to replace the damaged cells by implanting stem cells as a future therapy. So this is 1, 2, and 3 as future therapy. Now, what about Huntington's disease? So, خلاص, we remember Parkinson's disease. We have low dopamine. We have let's say, hypokinetic condition. It's a hypokinetic condition because they have slow initiating and executing movements. And they have this tremors at rest. In Huntington's disease, again, it's a degenerative disease. However, this disease is fatal and it's hereditary. It strikes during the middle age. Remember, Parkinson's was more in the elderly. Here it's in the middle age because it's hereditary. And it happens due to a mutant Huntington protein. Remember this. This Huntington protein is mutated and it accumulates in the brain cells and the tissue dies, which leads to massive degeneration of the basal nuclei and the cerebral cortex. So both Parkinson's and Huntington work on the basal nuclei. There was a degeneration of dopamine releasing neurons in the basal nuclei. Here we have accumulation of Huntington protein that leads to degeneration of the basal nuclei. So we are also suspecting a motor function problem. Now, what's the motor function here? What happens? The symptoms initially are wild, jerky, and almost continuous flapping movements called chorea. Chorea اللي هي the Greece for dance. Chorea. Okay? So they are hyperkinetic. Unlike Parkinson's, which is hypokinetic, they are slow and they have this shuffling, short gait. No, here they are hyperkinetic. They have this chorea, dance-like movements. They are very jerky, very wild movements. Although the movements appear to be voluntary, they are not, of course. And late in the disease, they will have marked mental deterioration. So Huntington's disease is progressive and usually fatal within 15 years. It is a hyperkinetic disease. The hyperkinetic manifestations of Huntington's are essentially the opposite of those of Parkinson's. So here we have overstimulation rather than inhibition of the motor drive. Huntington's is usually treated with drugs that block rather than enhance dopamine's effect. So because Parkinson is hypokinetic, we give dopamine. But here, because it's hyperkinetic, we block dopamine. So that's it. If you want to check Korea, I advise you to see some videos to see their jerky movements and have them in mind. And this is for our lecture today. I hope it was easy and clear. If you have any questions, feel free to ask at any time. And good luck. Thanks for watching.